Hi, everyone, and welcome to our second podcast of the IGCS Education Podcast on Malignant Bowel Obstruction in Gynecologic Cancer. I am Anisa Mburu, the Vice Chair of IGCS Palliative Care Education Workgroup, and I am joined today with my co-moderator, Dr. Peter Grant. Dr. Grant, it's nice to be back for a second time, and I'm excited for today's episode. How about you?
Yes, I certainly am. I think this episode will give us a great insight into palliative care decisions and ethical dilemmas we can encounter in managing malignant bowel obstruction at end of life.
Let's get started. And let's please welcome our guest speaker, Dr. Eduardo Burera from MD Anderson Cancer Center in the United States. Thank you so much for joining us today, Dr. Burera.
Perfect.
Please briefly introduce yourself to our listeners.
Thank you very much. My name is Eduardo Burera. I'm the chair of the Department of Palliative Care, Rehabilitation, and Integrative Medicine at MD Anderson. I've been practicing palliative care for too many years, and initially in Canada for 15 years, and then I moved to MD Anderson in 1999. And so I've been very involved, not only in palliative care in North America, but also around the world. And I am delighted to be able to participate, especially with our gynecological oncologists that, in my view, have always been the ones that have been closest to the cancer patients throughout the trajectory of their disease. So it's a great pleasure to be here.
This is amazing. You're the best person for this episode, clearly. And for this episode, you're actually going to let Dr. Burera share his knowledge and expertise on decision-making, ethics, and communication for malignant bowel obstruction. We're going to discuss quality of life, how to discuss management options, including benefits, risks, outcomes, and even go into some of the myths and facts during management options. So start with this. How do you assess and prioritize quality of life in patients with malignant bowel obstruction due to advanced gynecological cancer?
Yeah, thank you so much. This is a very serious complication in our patients because it affects not only their symptoms that might be quite different from one patient to another, but also a little bit of their expectations about one of the most important things we do in life, that is our own intake and nutrition. And so we have a patient that presents variable levels of symptoms, and what we try to do is always measure those symptoms, always measure them. And there's a tool we use called the ESAS, Edmonton Symptom Assessment Score. Is available in 60 or 70 languages. It has no copyright. You can start doing it today, and it takes less than 1 minute for the patient to do. And the patient will tell you about their pain, their nausea, their appetite, their fatigue, their depression, their anxiety, and their spiritual distress. Very easy, from 0 to 10. It's done in seconds, and that tells you a little bit of the price this problem is having on the patient. And the challenges we face are, first, abdominal pain is a huge issue. And when there is abdominal pain, some people say, well, the opioids might further compromise motility. Our answer to that is 100%. When the patient has pain, opioids are wonderful. These are the ways in which you are going to help that patient with the suffering due to this malignant bowel obstruction. Sometimes that is much less of a problem, and you might not need to take it around the clock. You might take it whenever you have this crampy pain that happens on and off. Most of the time, the pain becomes continuous, and therefore a continuous administration of the opioid is necessary. And what we have learned over the years is that the perfect way to do that is the subcutaneous route. You just put a needle under the skin and deliver your opioid every 4 hours. It can be done by the family. It's easy to do, and you can deliver that without having to rely on the GI tract of your patient. You can also have custom-made suppositories of medications such as methadone that can be delivered very easily twice a day in the patient with minimal cost. So there are ways in which one control the pain. The same can be said about nausea, vomiting that is happening in the patient. And the big question there is, how is all this impacting on the patient's well-being overall? What are the challenges to their well-being? Is this causing the patient concerns about starving to death? Is this causing concerns in the loved ones about starving to death? So some information, some understanding, but also some discussion about what is the price they're paying for potential dehydration or starvation is very important. And what I usually start is asking them, what are you worried about? What are you concerned about where you are right now? And try to guide the conversation on what they tell me is their main concern. Nutrition is part of every single social gathering, every single, even religious ceremonies have metaphors of nutrition. And therefore, there is a huge price that people feel they're paying for not being able to take in their nutrients and their liquids. And we try to discuss with them the difference between cachexia and starvation, that are different problems, and that unfortunately, when our factory is on strike, we can put a lot of chairs, or a lot of wood on the lot, but we're not going to get any chairs made because it's a strike of the factory. And when our metabolic factory is on strike, it not always helps that we pump amino acids and fatty acids and glucose into the patient, because they're not going to make the proteins, the hormones, the antibodies they need. And so if the patient was already a little bit cachectic before, as it happens very often, it's not that by forcing into them expensive and toxic treatments close to the end of their life, we're going to rebuild what had been lost due to this metabolic factory on strike. But it does have a big distress level on the patients, and particularly on their loved ones, who say, my loved one is now going to starve to death, and we need to have some discussion and conversation about the difference between starvation and cachexia.
That is very interesting, and I love how you put it about the price that they have to pay. And that's one of the questions that we actually wanted to know, especially when you're dealing with these patients. They're very sick. How do you make the decision, or how do you influence the decision and talk to them about how they're going to pursue aggressive management, or you're going to be more conservative in the management? Just how do you carry out that discussion in the balance between the two?
Yeah, I think the crucial person in that is the gynecological oncologist. The gynecological oncologist needs to understand and decide, what is the real prognosis of my patient? Are there therapeutic options for controlling that cancer that are still available? Are there still things I can do? Because if that is the case, then nutritional support is necessary until those measures can be implemented. On the other hand, when the bowel obstruction occurs in the context of those options not being there, then this is something that helps a lot in the discussion about what can nutrition per se bring, and what is the cost of parenteral nutrition as an intervention. And the cost is not measured in the money. That's irrelevant. The cost is measured in the comfort, in keeping an IV, infections, thrombosis, all those things that make the quality of life close to the end of life more difficult for that patient. And so it's very important to get the gynecological oncologist who the patient and the family trust participate in all the decisions regarding where is the patient right now, and then am I going to move towards the management of the symptoms associated with this problem, or am I going to work very aggressively at maintaining function? Some patients, a small percentage, present with a bowel obstruction, and they are having a very, very slowly progressing malignancy. And that is a special situation in which it might be quite appropriate to maintain some parenteral nutrition for that patient, because the quality of life is not affected and they might go for a long time. Most of the time, that is not the case. The bowel obstruction happens in the context of cachexia, happens in the context of the beginning of very poor performance status, happens in the context perhaps of the beginning of delirium also. And then what is the advantage for that patient of receiving aggressive nutrition is what we try to discuss. One of the items that might be of usefulness is what is brought by cachexia and what is brought by dehydration. Families are frequently very, very distressed when they are told that there's not going to be any fluids, especially because it's almost getting fluids is a rite of passage. Everybody who dies in a hospital dies with an IV. And then it's told that everybody who dies at home dies with no IV. And then in one case, you get a wet death. In the other case, you get a dry death. But the reality is that probably both are excessive. In some cases, the IV was not necessary in the hospital. And in many cases, the IV, the no IV was insufficient at home. And we have one very easy method that can replace the water at home when it's necessary. That is the subcutaneous hydration. It was used before the IV was developed. It was revamped later. It can be done by the family member. Just hang a bag on a hanger and deliver it by gravity, and the patient can receive with no pump, no infusion pump, just by dropping, can receive a bag of fluid subcutaneously. And the family might sometimes feel that by keeping the patient hydrated, even in the absence of nutrition, the patient's cognition is a little better and the fatigue is a little bit better. And it helps with the transition. It helps until the patient's delirium takes on and the patient becomes more unresponsive. And at that time, it becomes easier for the family to say, okay, well, we've done everything we could. And now the moment has come for the end of life. We don't need this hydration anymore. But moving completely from having the IV, the medications, everybody around you, to being at home with nothing is it's a tough situation for the patient. It's a tough situation for the family. And so that making the transition a little bit easier for them might help.
Great. Dr. Grant, you had a question?
Yeah, I was going to ask, in some situations, some communities, decision-making doesn't necessarily fall to the patient, but falls to the family, who are making decisions on behalf of their family member. And I'm just wondering, have you any sort of strategies for dealing with divergent opinions amongst the family about, or conflict in some situations about management of their loved one? How do we deal with that?
Yes, absolutely. And that's a wonderful point. And I think one of the crucial points to us, one of the most powerful tools is the family conference, is getting all those relatives together with us. And that usually does not include the patient, so that there is a bit more freedom for them to express their position. It's very important, if we're going to call a family conference, to understand that many times there's preceding conflict among the family members, conflict about roles, conflict about grudges that may have been there. So it's crucial that, first of all, we try to get a family conference with all those involved. Second, that we brief everybody who's going to get to the family conference. And that means that we will discuss the patient's well-being, treatment, and so on, and we'll try to focus and keep the focus there, rather than being an opportunity for people to express problems that have occurred before, and to guide the conversation around the management of the bowel obstruction in our patient, and what is better, what is worse, and the prognosis of our patient. So I think the family conference is a powerful tool. If one of our colleagues listening to this feels that there's a patient that might benefit, but they're not so familiar for how to manage a family conference, talk to a palliative care specialist nearby, get them involved. They might help you a little bit with guiding this family conference so that it doesn't become explosive, so that it remains a wonderful avenue for healing, an avenue for well-being. The one thing that usually gets these family they have in common is their love for the patient. That's why they want to get involved. That's what they want to participate. But their perspective of what is love might be quite different. In the case of the son, it might be prolong their life at absolutely any cost. In the case of the daughter, might be let them end their life independently and with dignity. And others might have religious beliefs around the end of life. And so it's very, very important to get them all there, generate some consensus. It's very important to block about an hour or so. You cannot do that in 10 minutes. It requires some quiet environment, not in the middle of the corridor, not in a very noisy area. Get them to a quiet area. Try to get everybody sitting and guide the conversation. And please remember to start that conversation with a briefing of what the limits are going to be of what we're going to be discussing, so it doesn't get out of hand.
Thank you. Anisa, back to you if you want. Have you got a question?
Yes, absolutely. I think one of the things that we'd also want to know, especially when you're dealing with these patients, talking about the risks and benefits of interventions like nasogastric decompression, venting gastrostomy, or even the drug therapies. How do you talk to them about this?
That's a wonderful point, Anisa, because the main goal, especially as the disease has already progressed, the patient is not responding to the treatment, and therefore we need to consider what is going to be the best quality of life measure for the patient. And I remember many, many years ago, we had visitors from the Netherlands in the palliative care unit when I was working in Edmonton. And they came to us, the two big government officials who were opening a palliative care unit in the Netherlands, because they didn't have palliative care at that time. And so they came and saw 3 patients with us. And then they called me apart and said, Dr. Burera, I'd like to discuss with you that we can never come up with guidelines here. It's going to be impossible. I mean, you guys practice in a weird way. We saw 50 patients with bowel obstruction. In the first patient, you guys thought it was very important to put an NG and then a PEG tube. In the second patient, you called the surgeon to do see if they could do a colostomy. And in the third patient, you did nothing. You just gave the patient some octreotide and Buscopan as a subcutaneous infusion. How can we come up with guidelines for the management of patients with this complication? And the answer was, of course, well, it's not, you need to put the bowel obstruction in context. It's the context in which this is occurring. And if in the first case, it is the frequent uncomfortable nausea and vomiting that are affecting the quality of life of my patient, absolutely, even close to end of life, an NG tube and a PEG can be wonderful interventions. On the other hand, if the patient has a slowly progressive malignancy and has a good chance at getting a surgical resolution of their GI motility, that sounds wonderful. And in the third case, as we're getting close to end of life and our cognition is impaired, our function is impaired, and now on top of that, we develop a bowel obstruction, purely pharmacological symptomatic management might be appropriate. So I think it's very nice to do the exercise of putting this complication in context so that you can make personalized decisions and never feel compelled to follow a guideline. The important thing is, yeah, there are some general concepts, but in my situation with this particular patient, what is the best course of action? And then you can make a personalized decision.
I love that, personalizing the decision for each patient. But at the same time, there's sometimes when you have to balance the hopes of the patient and the family versus the realistic expectations about prognosis and likely outcomes. How do you have those kind of conversations?
We think it's very important to stay with them, to continue to accompany them, and to slowly have them accept the fact that the end of life is coming. It's an incredibly difficult time for the patient, and it's a very difficult time for their loved ones. And so it cannot be done with a conversation. It can be done with a process. So if the patient is not willing, or the family is not willing to accept that the transition is happening, please don't get disappointed. Show up again, show up again, show up again, control the symptoms, ask them about their favorite soccer game, recognize them as persons, stay with them, and then at one point, as you build rapport with them, the relationship starts to evolve, and then the acceptance of end of life happens more often. Occasionally, it will never happen. People will just choose to never happen, and that's absolutely fine, because the same way as we're all different the way we live, we're all different the way we'll end our lives. And please do not get burned out because we're not succeeding at having this transition. It does happen to a proportion of our population. The important thing is that we never get to do things that we're uncomfortable with. That we think, oh my goodness, if I do this, I do it because they're pressing me, but not because I think it's the best for the patient. At that time, you can say, you're absolutely free to consult another colleague and see what they think. But from my perspective, doing this to you or to your loved one is really something that I don't feel very comfortable doing. I'm so sorry. I'll keep coming. I'll keep accompanying you. I'll keep being part. But that is a limit that I cannot cross, because if I cross that limit, I'm going to end up feeling bad for you and bad for me.
We're getting near the end of our podcast talk, but how do palliative care teams work with gynecologic oncologists to manage these patients, and what does good collaboration look like?
Absolutely. I think the most important thing is that the boss is the gynecological oncologist. The patient went to the gynecological oncologist because they had a cancer and they wanted the best relationship and care. So we in palliative care are good at the person, but we are not good at the gynecological malignancy. It's very important that any palliative care team regards the disease management as cardinal. That is what the patient would like, and that we work together in understanding what the goals of the disease is. Occasionally, I need to give them a call and say, listen, the patient you saw last time, I just saw them. Now they're bedridden. Now they're not moving around. Now they're beginning a little bit confused. Do you think we should discuss that? I think we are a little bit past beyond therapy, and then get them involved in them. I don't tell them. I get them involved in telling that patient that the situation has changed. And so, because we build a relationship with trust between the palliative and the gynecological team, then the gynecologist feels that we are covering their back, and we feel that they are also covering our back. So it's important that you build a relationship of trust with each other, so that nobody feels that what they're going to get on their message is going to be losing face to the other colleague.
Right.
And that's fantastic, because at least it makes us know that we're never alone when we're dealing with these patients. When we have a team around us, we support each other, we grow together, and then we're able to even talk to the family and relatives and give the patient the best care possible. This has been amazing, Dr. Eduardo, and unfortunately we are at the top of the hour where we have to finish. So I don't know, Dr. Grant, I think it was amazing, and I think we've learned quite a lot. What about you?
I could go on for ages, but we haven't got time. But thank you so much. It's been really interesting, informative, and useful.
Thank you all for everything you do for your patients. I always say that when we started palliative care at MD Anderson, the one service that believed in us and nobody else did were the gynecological oncologists. So we owe you so much for all you do for your patients.
Thank you so much, Dr. Eduardo, and thank you to our listeners. We do ask you to tune in again for the next time for our podcast in this series as we discuss future directions and cutting-edge research with our expert guest speaker who will focus on non-surgical management options and other important management decisions, including discussing symptom relief and medications. See you all, or listen to you all next time.